Hi, my name's Stephen, first year anatomy student, and today we're going to learn about multiple sclerosis. Okay, so what is MS? I want you guys to remember 3 points. It's an autoimmune disease that is caused from progressive demyelination of axons that occurs within the central nervous system. Now, the causes is a combination of genetics and environmental factors. So if you have the gene HLA-DRB1 or XX chromosomes, which means if you're female, you're more likely to have MS. But also if you've been exposed to the Epstein-Barr virus, humans herpes simplex virus 6, or if you have reduced vitamin D, you're also at risk as well. Now, the prevalence in Australia in 2021, there was about 33,335 people with MS. Now, that means for every 100,000 Australians, you're going to get 131 of them with the condition. So common symptoms include decreased mental function. So you can have depression, memory loss, and sexual dysfunctions. You also have eye problems. So people have vision loss, diplopia. So that's when you see two images, and abnormal eye movements. You also get reduced physical abilities. So you get weakened limbs, weakened facial muscles, loss of balance or coordination. And you also get urinary and bowel incontinence or retention. Now, there's a interesting symptom or phenomenon. We call this the Uthoff's phenomenon. This occurs when the patient increases their body temperature, and this can be from exercise or from like a hot shower or bath. And when the temperature increases, their symptoms also gets worse as well. Now, the good news is that when the temperature reduces to normal, the core temperature reduces to normal, their symptoms also reduce as well. So before we learn about how the immune system attacks the body, we got to do a little bit of anatomy. So we're going to look at the central nervous system here, where we focus on the brain lobes, cerebellum, brainstem, spinal cord, and neuron. Now, the brain lobe, you have the frontal lobe, which contains the primary motor cortex there in green, and its role is to send messages for you to be able to move your muscles. The frontal lobe also helps control emotions and thoughts. And so behind that, you've got your parietal lobe. Now, in blue there is the somatosensory cortex, allows you to feel things like pain, touch, and temperature. Next, you have the temporal lobe. So it allows you to smell, taste, and hear sounds, but also for memory storage. Now, at the back, you have something called the occipital lobe, and this receives all the information from the eye, processes it, and allows you to see different images. Under this, you have the cerebellum. So it contains sensory information from the eyes, ears, and muscles, helps you coordinate your movements. And then you got your brainstem. So the brainstem is made up of 3 parts. You got the midbrain, pons, and medulla. It contains cranial nerves 3 to 12, and it's responsible for breathing, consciousness, blood pressure, heart rate, and sleep. So important to note that cranial nerves 1 and 2 comes directly from the brain as well. So the spinal cord contains the gray matter there, which is neuron cell bodies, and it also has this white matter, which is myelinated and unmyelinated axon tracts. Now, these tracts act as a freeway for messages to travel from the brain to the periphery and also from the periphery back up to the brain. And so if we break down these tracts into smaller areas, you notice that the left side here highlights the sensory areas, allows you to feel touch, pain, temperature, proprioception and vibration, and the right side is the right image here is the pathways for the motor neurons, which innervates the limbs for fine movement, balance, posture, and allows you to walk. Now, if we look at the smallest unit of the central nervous system, you have your neuron. And so the neuron at the end here contains dendrites, and these dendrites receive chemical messages called neurotransmitters, which helps send the message down the neuron. It has the cell body that has a nucleus and other organelles in there to keep it alive. And it also has an axon. Now, the axon conducts electrical signals from the cell body all the way down to the axon terminal here, and it's supported by a cell called an oligodendrocyte. Got to remember that the oligodendrocyte is only found in the central nervous system, and its role is for axonal support and also helps build this myelin sheath around the axon. So the role of the myelin is to insulate the axon and helps the electrical signals travel through a lot more efficiently. And so in MS, these areas get affected. Okay, so if we look at the immune system, the T cell is a cell that goes around the body and tries to find things that doesn't belong there. And so it reads an antigen on an oligodendrocyte and it mistakes it for a viral antigen. And so when 2 antigens are very similar to each other, we call this molecular mimicry. And so when it thinks that the oligodendrocyte is is a virus, it's going to start releasing something called cytokines. Now, cytokines recruit more blood cells into the area. It causes vasodilation, which means your blood vessels get bigger, which means more blood flow. And it also increases capillary permeability. So this makes the gaps between the blood vessels a lot bigger, which means more blood cells can travel through. More white blood cells can cross them. Now, when you have all these white blood cells, it starts attacking the myelin and oligodendrocyte. Eventually, it leads to reduced action potentials and also scar tissue formation. And this scarring is called plaques. And we can see these plaques from an MRI scan, and it's highlighted there in white. And the plaques are also called sclera. And when you have multiple plaques, multiple sclera leads to the name multiple sclerosis. And so depending on the location of these plaques, it can cause different symptoms. Now, one of the common symptoms is decreased visual acuity, which has to do with cranial nerve 2, which is the optic nerve. And the role is to send messages from the eye to the brain. And you can imagine that if the nerve is demyelinated, no messages are going to get through and patients won't be able to see. Now, common things that happen here is optic neuritis and a relative afferent pupillary defect, which we'll talk about next. So top left, you have your optic nerve. Now the optic nerve, this is a normal optic nerve, and down here, you've got a swollen optic nerve. So this is optic neuritis. When you shine a light into a normal nerve, the pupil constricts. But when you shine a light into a nerve that's swollen, the pupil stays big. This is because messages aren't getting into the brain for it to tell the iris to get smaller. And we call this an RAPD. You also get eye muscle problems. So bilateral internuclear ophthalmoplegia is when the eyes can't turn towards the nose, and it has to do with a lesion within the medial longitudinal fasciculus within the brainstem. So when we look closer at this, if you look down here, you have your abducens nerve, which is cranial nerve 6, and the role of this nerve is to innervate the lateral rectus and allows the eyes to be pulled out towards the ears. Now, at the same time when this is happening, a message is meant to be sent through the MLF to cranial nerve number 3, which also innervates the medial rectus and allows the eyes to move in the same direction. So if you look at yourself in the mirror, when you look left or right, you can see that both eyes move together and you can't move them independently. But when you have this condition, it affects the MLF. And so you can see that the cranial nerve 6 innervates the lateral rectus, eye moves out. But because the MLF is affected by multiple sclerosis, the medial rectus is not getting the signal, so eye stays in the same place. And so this condition affects both MLFs, which means both eyes will get stuck in the middle and they won't be able to turn towards the nose. Okay, so you also get issues in the face. Now, the face has a trigeminal nerve there, so cranial nerve number 5 allows you to feel things. So you get trigeminal neuralgia if there's lesions there, causes sharp pain in the face. But you also have cranial nerve number 7, which is the facial nerve, and the facial nerve controls all the muscles of the face. And if you can't control those, then you don't get any facial expressions. So you can't smile and you can't frown, for example. Patients also have issues with speech and swallowing. So if you get lesions in cranial nerves 9, 10, 11, and 12, you start having difficulty swallowing, difficulty producing sound, difficulty talking, you get a hypergag reflex and a spastic tongue, which makes sense because if you have lesions in this area, these nerves control your tongue, your throat, and areas around your neck. Okay, so if you have lesions of the spinal cord, it depends on the location of the lesion. So if it affects these sensory areas, you start to get decreased proprioception, decreased touch, pain, and temperature sensations. If it affects the motor pathway, you get weaknesses of limbs, loss of balance, and ataxia, which is also known as no coordination. Now, the higher order centers in the brain, so if it starts affecting areas of the brain lobe, you can get decreased serotonin, which means you get depression. Patients also get decreased memory. Now, if it affects the sympathetic pathways, it can also cause incontinence of your urinary and fecal tract. Now, the reason why is because the sympathetic pathways is meant to help sphincter muscles hold together, contract. But when you can't control them, they get released and you can't hold in your contents. But if it affects the parasympathetic pathways, this means that the muscles can't relax and it's contracted all the time, and then you get constipation, for example. All right, so that's it for the presentation. Thanks for listening, and I hope to see you again next time. Bye.